All right, very good.
No.
So I guess we'll get started. Just let me know if there's any audio or video issues that we encounter as we go, Rachel.
Okay, we'll do it.
Again, I'm Dr. Gnirke. Matt's my first name. I'm a physiatrist, and back pain is certainly one of the specialties that I treat, or one of the diagnoses I treat in my specialty on a daily basis. This is a very common cause of patients coming to the doctor, and so I figured it'd be a great topic to give a bit of an overview on in terms of some underlying anatomy, causes, and treatment options that are out there for back pain. So I'll start with a couple disclaimers. So I have about 35 slides. I'm hoping to get through them in about 30 or 35 minutes. I plan to spend about an hour together, so I'm hoping to have about a half hour to answer any questions. So please, if anyone has any questions, feel free. I do have two very cute but excitable dogs at home as well. So if they start barking, I apologize. If they meander in, I will give them a cameo. And that's pretty much that. So let's get started. So let's talk a little bit about back pain for the next hour or so. So back pain, why do we care about back pain? Well, it's exceptionally common. Pain stinks. We all experience back pain throughout our lives. Often it's a self-limited acute episode, but can be more of a chronic daily issue, which is where us as physicians often get involved. It's responsible for a considerable amount of time away from work and therefore lost wages and productivity. So not only does it affect us from a physiologic standpoint with regard to the creation of pain and dysfunction, but also affects us financially, personally, and psychologically. In the United States, over $200 billion is lost every year in wages and productivity due to back pain. So it's certainly a very common diagnosis that requires treatment to get folks not only feeling better, but get them back to work and doing what they like to do from a leisure and recreational activity standpoint, especially up here in Summit and Eagle County. So I like to start the lecture by looking at anatomy. So I think good understanding of anatomy is exceptionally important when it comes to diagnosis and treatment of back pain. So a third of the lecture is really focused on the anatomic underpinnings of back pain, and then we'll look at causes and treatments. So when we look at the spine, it looks intimidating. It's very complicated. It really is comprised of repeating units, which makes understanding more easily accomplishable. In the cervical spine, we have 7 segments. In the thoracic spine, we have 12. Lumbar, we have 5. And the pelvis or sacrum is variably fused in most patients. Our spine provides us a backbone, no pun intended, for all our physical activity. It couples the movement of our legs and arms and allows us to do all of the amazing human things that we're able to do, such as standing upright and running and riding bikes, etc. Not only is it important in providing structure to our body for physical function, but it's also a protective sheath, a shield for our neurologic system. The central nervous system is housed by the spine and skull, and our nerve roots are also contained within our spine. Beyond being a bony and protective structure, the spine also has a very complex muscular system that attaches, originates, and inserts to and from the spine. And there are very strong ligaments that provide structural support to the spine that also can be injured. Really, all of these systems are causes of pain that we'll look at in more detail. So now we'll zoom in on the lumbar spine. So the lumbar spine is the area of the spine that we see most commonly as a cause of pain and are most often providing treatments for. We can see here that repetitive unit structure where we have a vertebral body separated by an intervertebral disc, and that structure continues throughout the spine. This is the front portion of the spine, and this is the back portion of the spine. These are the bones we can feel through the skin or our spinous processes. The intervertebral disc is another important structure within the spine that provides not only support, but also shock absorption to our activities, and is a very common source of pain. We can see posteriorly, or on the back side of the spine, each vertebral body is attached to its neighbor by a facet joint, and these joints allow motion and rotation of the spine. And then importantly, between the facet joint and intervertebral disc is an area we call the neuroforamen. The neuroforamen is a Latin term that means nerve window. So this is the nerve exiting the spine through a little window that's created by the height of the disc and the shape of our facet joint and vertebral body. You can imagine if you develop pathology such as a disc herniation or an enlarged facet joint, we can develop nerve pain as a result of that. So we'll keep looking at this, but in another view. So this is an axial view. So this is essentially a cross section through the disc. We can see that each intervertebral disc has two portions. There's the nucleus and the annulus. The nucleus is essentially our gel-filled center of the disc, and this provides our shock absorption properties from the disc. The annulus is a more fibrous and dense portion of the disc that essentially helps to hold the gel or shock absorber within the confines of the nucleus, and also provides structural support to the disc. And then moving posteriorly or backwards towards our skin of our back, you can see here within our central canal, our bony central canal is where our nerves live. In our neck and thoracic spine, this would be the spinal cord, whereas in the thoracic spine, this is our cauda equina, essentially an important collection of nerves that's protected by the vertebral bone. And we can see here as well the nerve exiting at this level. And then very posteriorly, we see a portion of the facet joint, which we'll go into in more detail. So let's keep looking. So that was our lumbar spine. As we continue to go inferiorly or towards the buttock, we see that the sacrum and coccyx are also important portions of the spine. You can see that the sacrum is essentially a fused bone, and there is a small joint between the sacrum and coccyx. There is another important joint in the pelvis called the sacroiliac joint, and that's formed between the sacrum and the ilium of our pelvis, and can be another important source of pain that we'll take a look at. And in summary, really any of these structures throughout the spine can be a source of pain, from the tip of our coccyx, called coccydynia, to the top of our neck. And we're going to look at some of the more common causes of pain in this lecture. I think it's not an exhaustive list, so certainly there are other causes that some of the participants here may experience and know about, and happy to answer any questions on more detailed diagnoses. But we'll look at some of the more common ones that essentially almost every human suffers from one or another throughout their lifetime. So when we look at causes of back pain, by far and away, the most common cause of back pain is muscular pain in terms of acute onset of pain. So this was, we're out in our garage, changing our oil, we're doing yard work, we were running, we're skiing, and we have an acute onset of axial, so pain in our back. Typically, this is the result of a muscle sprain or strain or pull, rarely a high-grade tear. This can be the result of injury or repetitive lifting, poor posture. These types of pain tend to be pretty self-limited and often don't present to a physician. They tend to smolder out on the order of days to weeks. Typically, these are treated conservatively with rest, activity modification, anti-inflammatories, and physical therapy. Muscle pain, while a very common and benign source of pain that typically improves on its own without directed medical treatment, can also be a clue that something deeper is occurring in the spine, be it to the intervertebral disc or the facet joint or our nerve roots. And so while we feel fairly comfortable managing muscular pain conservatively, we do have to keep an eye out for any other associated symptoms that may be a clue to deeper spinal issues and require more targeted treatments. So now we'll take a deeper dive into the intervertebral disc. So as a reminder, the intervertebral disc is our shock absorber. Two portions. The center portion is the nucleus, which is our shock absorber. It's our gel-filled center. And the annulus is our more fibrous collagenous structure that helps to hold the gel where it should be, so it can provide our shock absorbing properties. Degenerative disc disease is an exceptionally common diagnosis. And when I discuss this with patients, I always say degenerative disc disease, because it's not truly a disease. It's a condition of the human spine. It's like gray hair. It's something that we all develop. Typically, approximately 40% of patients by the age of 40 have some degree of notable degenerative disc disease on imaging, and 80% by the age of 80. This is a slowly progressive process associated with wear and tear over time. This can be associated with pain, although not always. There are certainly plenty of folks out there with fairly severe degenerative disc disease that are relatively pain-free and physically active. As the discs wear, not only can they produce pain, but also can produce alignment abnormalities such as degenerative scoliosis or different rotations or lithesis in the spine where our alignment becomes abnormal. And that can have a larger impact on our nerves, as again, we can see the close approximation of our nerve root to the intervertebral disc. And when we develop these osteophytes or bone spurs, as part of the degenerative cascade, often that is associated with pinching of the nerve and nerve pain down the arm or leg. Beyond our typical wear and tear that we all experience, there are other injuries that can occur to the disc, and these are more common causes of disc pain in our younger patients, so our 20, 30, 40-year-olds who lifted something heavy or sneezed and have acute onset of back and leg pain. These are more common types of pathologies that we see, and they can include issues with both the nucleus and the annulus. The annulus itself can become torn, just like a rotator cuff or a tendon. And the nucleus can also herniate through the annulus and produce a disc herniation. This disc herniation here produces a phenomenon known as spinal stenosis, where there is tightness or pinching of our spinal cord or nerve roots, which can occur either within our central canal or within the neuroforamen and affect individual nerve roots. And these have different symptoms depending on the location of the pathology. In terms of causes of disc pain, so there's been quite a bit of research over the last several years looking at causes of disc pain. We used to think, simply wear and tear, and certainly that is the case where repetitive lifting and poor biomechanics or labor-related jobs can worsen disc pain and disc degeneration over time, and that's absolutely true. But it's come to light that our genetics, so what we inherit from our parents, actually is just as important, if not potentially more important than what we do with our bodies. And so some patients are unfortunately predisposed to develop degenerative disc disease, particularly at an early age. And you see this in families where there tends to be several family members who have received spinal surgery, particularly spinal fusions, especially at young ages in their 30s, 40s, and 50s. There often tends to be a genetic component to that presentation, and that's being further researched and may potentially be a target for treatment in the future, although unfortunately is not currently. In terms of symptoms of disc pain, again, this may be symptomatic or asymptomatic. Not everyone that has degenerative disc disease has back pain, but certainly those that do and have symptoms often describe it as a deep ache that can radiate. Often that radiation is to the buttock, but not beyond. If we are experiencing significant leg or arm symptoms, typically that indicates that we have a pinched nerve or a radiculopathy, where the disc is not only degenerated, but it's causing pressure on our nerves. Disc pain is highly variable in terms of how it affects patients on a day-to-day basis. It can be very chronic in nature, where patients feel daily pain and fatigue and stiffness as a result of their degenerative disc disease, or it can be very episodic, where patients feel like they quote unquote throw their back out, between one and a handful of times per year, with episodes lasting on the order of typically days to a week or two, and then smoldering out and improving in between episodes. Typically, disc pain can be differentiated from facet joint arthritis by provoking maneuvers. So activities such as lifting, forward flexion, prolonged sitting all load our disc and can cause disc pain. Valsalva maneuver, where we are coughing, sneezing, having a bowel movement, things along those lines where our intra-abdominal pressure is increased, can also exacerbate disc pain, as the intra-abdominal contents can essentially cause pressure on the disc, which can be painful. Typically during acute flares of disc pain, pain is relieved by laying flat. So often we see patients that throw their back out and have symptomatic disc disease, often lay in bed for a day or two or three, and then slowly return to their normal activities thereafter, is a very common time course for symptomatic disc disease. The next major structure is our posterior structure. So we looked at the disc in the front. Now we're going to take a look at our facet joints in the back. At each vertebral segment, there are two facet joints on each side at each level. And so This, for example, would be our L3-4 facet joint on the left and right, and our L4-5 facet joint on the left and right, and so on and so forth. And these joints are largely involved in rotation of the lumbar spine. We can see with the schematic on the right that the shape of these joints really allow for significant rotational movement of the spine. They also allow for extension, and those tend to be provoking maneuvers when we develop arthritis. You can imagine if you develop arthritis, say in this joint on the left, and you develop a bone spur in this region, the facet joint won't be as free to perform that rotational activity. And so therefore, we often feel stiffness and pain with activities that involve standing upright and rotating our spine. In terms of what that looks like, this is a CGI picture, obviously, but it represents what facet joint arthritis looks like fairly well. We can see at the L3-4 level up here, these facet joints are normal and can easily glide between each articular process here. Whereas at the L4-5 level, we see this graphic represents development of significant arthritis on both sides. Associated with arthritis in our joints often are bone spurs, and these bone spurs limit motion and are associated with pain and irritation in the joint with repetitive movements. And that seems just inherently true from a mechanical standpoint, so it's fairly easy to understand how that would cause pain and stiffness. When we talk about symptoms, and I've gone over this already, but often associated with stiffness, facet joint arthritis, this pain tends to be worse in the morning in most patients and then tends to loosen up throughout the day, assuming a relatively benign daily schedule. If we're doing a lot of hiking, up or downhill, or we're doing a lot of lifting, repetitive motions, certainly facet joints can become flared up quite easily with repetitive motion. And often this is described as your achy, breaky back pain. So this tends to be more of a chronic daily issue. It can undulate up and down over time in terms of severity, but often this is something that a patient experiences quite regularly and is functionally limiting with any prolonged activity, unfortunately. So next we'll talk about nerve pain. This is another schematic of the lumbar spine. Nerve pain can occur due to many issues in the spine. This graphic represents a disc herniation, and we can see how that disc herniation occupies space within that neuroforamen, or the exit point for that nerve, and causes pinching. This would cause pain down the leg, typically, so down through the buttock, the outside of the thigh, and then to the front of the lower leg. In most patients, these nerves go to very typical locations. So depending on where our symptoms are in our arms or legs, we can often determine which level is most likely involved in our pathology. Not only can these disc herniations affect the nerve root, but also can affect the central canal, which can be a bigger issue, particularly in the cervical and thoracic spine where our spinal cord is housed. Obviously, the health of our spinal cord is exceptionally important for our overall physical function. And so if we do have a disc herniation that instead of pinching on a nerve is pinching our spinal cord, that is a more urgent medical issue and often requires a referral for neurosurgical intervention with Dr. Braxton, which we'll talk about in some detail at the end. Nerve pain, I think this is also something that most patients and people, myself included, are familiar with, either from our spine or other causes of nerve pain. It's often described as just a sharp shooting nerve pain. Everyone knows what that means. There are often associated symptoms with nerve pain, and they can include this phenomenon of paresthesias. So that can include numbness or tingling or burning in our legs, so altered sensation or painful sensations. Nerve pain very often radiates to specific areas of our arm or leg, depending on which nerve is involved. And unfortunately, can also be associated with neurologic deficits, particularly weakness is what we notice most obviously, but also can be more subtle neurologic deficits such as clumsiness of our hands or decreased balance in our legs or changes of control of our bowel or bladder. So all of these symptoms are important to keep in mind in addition to the pain when formulating a treatment plan that's most likely to improve the patient's symptoms and improve their function over the long term. And so we've looked at now the major sources of pain from the spine. So we have disc pain, arthritis-related pain, and nerve pain, which can be related to disc pathology and Faceturing arthritis. So now we'll take a look at just a couple other common sources of pain that we see. So SI joint pain, sacroiliac joint pain, another common cause, more of buttock pain than back pain. This too can produce what's termed a pseudo-radicular pattern of pain. So typically the SI joints hurt in the buttock where they exist, but it can cause referred pain down the leg and can feel quite a bit like a pinched nerve in our back, which is where imaging is often helpful to parse out the underlying diagnosis. The SI joint, unlike our shoulder or hip joint or elbow joint, really does not have significant range of motion. It's more of a keystone joint, like the keystone of an arch, where its purpose is not to provide motion or range of motion, but instead its purpose is to couple the forces that are generated in our legs through our spine. So it essentially couples our legs to our spine and can be a very common source of pain, be it from degenerative issues or instability, etc. So when we look at symptoms of SI joint pain, highly variable overall, can be described as an aching pain in our buttock, can be sharp and shooting pain down the leg as well. This type of pain is often exacerbated by motion in our lumbar spine and legs, particularly transfers. So one of the more common areas that folks have pain, or common scenarios that we see pain stemming from the SI joint, is with a sit to stand transfer. So if we're sitting, say working on a PowerPoint presentation for a couple hours, and then we decide to get up and get a glass of water, that sit to stand transfer, where we transition from a seated to a standing position and take our first few steps, is often a significant provoking type of activity for SI joint pain. It can be a clue in the history to help parse out SI joint pain from disc herniations or other sources of pain. The SI joints are commonly affected in terms of initiation of pain after childbirth, trauma. Just like any other joint, they also can develop osteoarthritis or edema or inflammation associated with them, similar to facet joint arthritis. And often pain is improved with compression. So often patients, particularly postpartum women that have instability of their SI joint and have pain and irritation as a result of that, will feel relief with an SI joint belt, which is essentially a small back brace that's worn over the SI joints. So finally, in terms of causes of pain, we'll look at fractures. Being up here in the mountains, we see quite a number of fractures as the underlying source of pain. I've seen a few this week come in that were undiagnosed. Most commonly, these fractures occur to the vertebral body. So our vertebral body is the front portion of our spinal column in between our discs. These are very common as a result of falls. So we see a lot of these in the wintertime after folks fall when they're skiing or snowboarding, or they fall while they're out walking their dog on ice. Other areas, essentially all other areas, but particularly the processes of our spine. So these little wings here are transverse processes and our spinous processes, which are essentially muscle attachment points, can also be injured and fractured as a result of trauma. Luckily, the vast majority of these traumas, be they compression fractures or transverse process fractures or spinous process fractures, the vast majority are treated non-operatively, where we treat patients with a restrictive brace to limit motion through that segment and support healing. And then typically these fractures heal on the order of 8 to 12 weeks, and patients return to their normal activities thereafter. So luckily, the most common fractures that we see are really not a huge deal at the end of the day, are just requiring of some downtime and relative rest, and often they heal and folks get back to doing what they like to do. So now we've looked at some of these really common causes of back pain that I see every day. One important point to bring up is that it's rarely just one thing that's causing back pain. Typically, patients come in and they have degenerative disc disease and arthritis, and they have some degree of spinal stenosis or tightness around their nerve roots. They may have associated muscle pain and spasm. And so our job as healthcare providers, particularly spine physicians, is to get to the root cause of our issues. And so often there's a primary pain generator that is producing the vast majority of pain, that if treated, some of these other causes of pain will quiet down on their own, as some of the compensatory mechanisms that we use to treat our pain ourselves, just by changing the way we move and the way we stand and walk, are changed through treating the underlying pain generator. So often there's a fair bit to sort through when we have back pain, but it's certainly an accomplishable goal. So next, like, well, why treat back pain, right? Why not just do some PT, take some anti-inflammatories? If you still have pain, just live with it, right? Well, the issue with pain are these vicious cycles. So there's both physical and psychological cycles that occur as a result of pain. So when we have pain, particularly chronic pain that's been going on for several months or more, we tend to avoid activities that cause pain, and that leads to deconditioning. That deconditioning brings along with it increased pain sensitivity. So decreasing activities are often associated, or decreased activity levels are often associated with increasing levels of pain, which leads to this further fear avoidance, on and on. And throughout that cycle, pain is not just the sensation, right? So pain is an emotional experience that we feel in our brain. And so when we have chronic pain, we often feel other symptoms, and those can include anger and anxiety and fear. When we have these symptoms chronically, that often is a downer on our mood and often can lead to clinical depression. Depression has been shown to be associated with a increased sensitivity for pain. So stimuli such as walking or moving, that activities that previously were not painful often become painful when we have mood issues. And so both pain itself as well as associated mood issues are extremely important targets of treatment to improve function and get folks back to doing what they like to do and feeling the way they like to feel. So how do we diagnose back pain? We see some common causes. How do we help figure out which one it is? Well, first, taking a very careful history is important. So we go through aggravating and relieving factors, the timing of your symptoms, how it started, when it started, how long you've had symptoms for, do these symptoms come and go, are they exacerbated by certain activities, etc. Once we have a good understanding of the historical background of our symptoms, then we perform a physical examination, check not only on the source of back pain, but also on associated symptoms. So a thorough neurologic examination is often warranted, especially for new patients with new issues, to make sure that we're not missing any weakness or numbness or balance issues that can often be associated with pain, although not often the primary concern for people coming into clinic. And then finally, once we have an understanding of the history and how a patient's body moves and reacts in a physical examination, then we often consider imaging. And so imaging is important nowadays in medicine when we're thinking about targeted treatments for pain. You can see this image on the right is of the lumbar spine. And two of these discs look unlike the others. So this is a process known as disc desiccation, where our nucleus or gel-filled center can become drier over time. And it loses its shock absorbing properties and often is associated with small tears in the disc, which you can see are these little white dots of fluid where it shouldn't be. And so this type of disc is often quite painful and can be quite painful in an otherwise healthy, active person. So let's talk about treatment. So there's lots of treatments for back pain, and they fall into kind of 5 general categories. I have a couple of slides just on some preventative thoughts on back pain. I think when folks participate in lectures like this, they like to come away with a few tidbits that they can, immediately incorporate into their life. So this is a study looking at sitting posture and disc pressure. So the more pressure our discs experience, often the more pain we feel. And we can see here a posture where we're slightly forward flexed actually leads to quite a bit more pressure through our disc than sitting upright in an erect posture or even leaning back. And so patients that have significant and symptomatic degenerative disc disease or annular tears or disc herniations often ask me about posture and how posture can improve or worsen their pain. And what I typically tell them is try not to be too strict with yourself about posture, because a perfect posture of sitting upright actually leads to more pressure through our discs than slightly reclining. And so individuals that have disc pain that's chronic or intermittent in nature and are taking a long car ride or have a project they're working on the computer, often sitting with a slight recline to their posture can be quite helpful in minimizing the pressure and therefore the pain through the disc. Sleeping is another area that I talk about commonly with patients. Most of us spend about a third of our life in bed sleeping. And I often get questions about mattresses and pillows. And unfortunately, there's no clear answer in terms of which mattress is best or which pillow is best or worst for pain. Often it's a period of trial and error. Typically, patients with chronic spinal disorders do prefer a more firm mattress. But what's most important outside of the firmness or kind of type of mattress that you use is how we treat our spine when we sleep. So it's important to maintain a neutral spine and pelvic alignment as we sleep. And so we can see here, if we're a side sleeper, the best position is to put a pillow in between our knees, and that helps to support our legs, keep our pelvis nice and level, and therefore it keeps a nice straight spine from our pelvis all the way up to our neck. If we're a back sleeper, we can instead place that pillow underneath our knees, and that again helps to minimize any tilting through the pelvis, and again maintain that nice neutral spine as we sleep. So just a couple quick tips that everyone can incorporate in terms of reducing pain from sitting and sleeping activities that we do quite a bit every single day. So beyond there, let's talk about actual treatment for pain. So initial treatment is often done by the patient at home. So I've certainly done this to myself before, and I'm sure pretty much everyone out there on the video tonight also has treated their own pain at home. And so typically acute onset of low back pain will require some degree of rest, typically on the order of 2 to 3 days, where we're limiting activities. Interventions that are available at home include over-the-counter anti-inflammatory pain medications, ice and heat. If you have a back brace, that can be helpful, particularly for those intermittent flares of disc pain. And light stretching can be helpful to maintain motion through the lumbar spine to ensure we're not getting too stiff through these episodes. If you are experiencing neurologic deficits, that's a different equation. So instead of seeing if we can treat this at home for a few days, if you're feeling weak or numb, or our balance is significantly affected, or we have clumsiness of our hands or lack of control of our bowel or bladder, these are red flag symptoms to come in as soon as possible and get that evaluated so that we can understand what the underlying diagnosis is and ultimately get started on a more targeted treatment plan more quickly. All right, so once we treat our pain for a few days at home, if it's still persistent, often what we will prescribe is hands-on treatment. So this typically consists of physical therapy, but also can consist of things like acupuncture, massage, chiropractic care. We're going in and having another person help us with our pain with hands-on treatment. Physical therapy I like because there are many different types of treatment that a physical therapist has in their armamentarium to help with your pain. These, especially initially, include things like manual therapies, where we're doing things like massage, dry needling, cupping, electrical stimulation. But then ultimately physical therapy progresses, and the important shifts from improving pain to improving physical function. And that's accomplished through core strengthening, improving our pelvic flexibility, and making sure that we're using proper biomechanics throughout our life with lifting and moving, walking. And then finally, the long-term goal of physical therapy is really to make it your own. So to take physical therapy home with you. And so physical therapists will help you develop a home exercise program that's really focused on your specific needs with your lumbar or thoracic cervical spine, that typically includes some component of core strengthening and some component of pelvic flexibility. And it's important to do these exercises regularly to maintain core strength. Core strength is important because it helps to support our spine. So it offloads our discs, it offloads our facet joints, and provides support to those structures. Beyond physical therapy, often medications are used for more severe pain, especially. These fall into a few categories. We try to be as targeted as we can with these medications to get the maximum positive benefit with the minimum amount of side effects, as each of these medicines has their own unique side effect profile. Anti-inflammatories, be they non-steroidal or steroidal anti-inflammatories, are often a first-line medication treatment, and they are available both over the counter as well as prescription strength alternatives. Anti-inflammatories can be upsetting to the stomach, and you have to be careful with patients that are on blood thinners or have kidney issues. So there are some limitations there, and not everyone should be taking anti-inflammatories. Other common and targeted medications include muscle relaxers for the associated muscle spasms that we often experience with deeper spinal issues, as well as nerve pain medications such as gabapentin or Lyrica for leg or arm symptoms. Antidepressants are also used as both pain management tools as well as for improving mood. There are certain antidepressants such as Cymbalta and venlafaxine, which have been proven to be effective in improving pain over the long term, but also they can be used for that left side of the vicious cycle where our mind gets affected by our pain and we develop depressed mood, etc. We rarely use opiates chronically for back pain, and certainly they are a treatment of last resort, either for extremely severe acute pain or extremely refractory chronic pain that has not been responsive to other treatments such as time, physical therapy, other medications, and targeted treatments, which we'll go over next. So the last part of the talk is where I'm most interested in, and those are our interventional treatment options. So these are targeted treatments. We have to have a very clear diagnosis based on our history, physical examination, and imaging. And what we essentially do is deliver targeted treatments directly to the site of pathology. So be it disc degeneration, spinal stenosis, or pinched nerves, Faceturing arthritis, SI joint pain, these treatments are delivered directly to the site of pain. And there are various types of treatments that can be used, and I'm going to go through several of the more common ones. And there are others out there. I'm happy to answer any questions that folks have on this topic. So first are steroid injections. So steroid injections are a mainstay of interventional care for pain, be it spine pain, shoulder pain, knee pain, etc. And so steroid injections can be used for arthritis, be it of your facet joint or your SI joints. It can also be used for pinched nerves due to spinal stenosis or herniated discs. And it is not typically used for disc pain, or it has highly variable response rates when it comes to disc pain. We don't like to inject steroid into the disc as it has negative effects on the health of the disc. So these treatments are mainly used for our nerves and facet joints. Steroid injections are, in my opinion, a gift and a curse. So they are extremely helpful for most patients, not all, but most patients who are experiencing an acute onset of pain. They tend to have a relatively immediate onset within a few days or week of the injection. But unfortunately, they do not change our anatomy. So they do not reverse our arthritis, they do not improve our spinal stenosis. So they typically have a short-term duration of effect on the order of months. Most commonly with steroid injections for back pain, we see on the order of 3 to 6 months of significant relief. And they can be repeated quite safely on the order of every 3 to 6 months if necessary, if this is a recurrent or chronic issue. They do, just like medications, have side effects. Our bodies produce their own steroids, which are important for fighting infections and supporting our blood pressure. Delivering exogenous steroids, or me injecting you with steroids, can reduce our body's ability to produce its own steroids. And some patients, up to about 10%, are more sensitive to that issue. They also can raise our blood sugar and blood pressure in most patients just a little bit and not a significant amount for a few days up to a week, although patients with relatively uncontrolled hypertension or high blood pressure or diabetes can experience more significant swings in their blood pressure or blood sugar, respectively. So again, we have to be careful about side effects with these interventions, but certainly can be a very useful tool for managing severe acute pain on the order of several months. Next, we have radiofrequency ablation. So this is a relatively newer treatment. It's not new, but newer. And radiofrequency ablation essentially treats the pain pathway. So we can see in this drawing, our facet joints are connected to our neurologic system, ultimately our brain, by these little nerves called our medial branch nerves. And so these nerves provide the pain signal from our joint to our spinal cord and to our brain. And so an ablation is aimed at treating arthritis-related pain. And arthritis is very common, and we use it not only in the spine, radiofrequency ablations, that is, we use them not only in the spine for facet joint and SI joint pain, but also in the shoulder and the knee and the hip. So these are semi-permanent interventions where we go in and create a small lesion with electricity right along that nerve. It's done through essentially a needle. So this is an outpatient procedure similar to an injection. This lesion essentially kills the distal portion of the nerve that is carrying that pain signal, and typically provides on the order of approximately a year of significant pain relief. For better or worse, our peripheral nervous system does have the ability to regenerate and regrow. And so these nerves will slowly regenerate and grow and reinnervate the joint. When they do, typically our pain returns. And that's typically on the order of approximately 12 months post-procedurally. This procedure can be repeated quite safely yearly. So let's talk about another topic. So this is the topic that I'm most interested in. And I'm going to turn my light on since it's getting dark out. So I'll be back in 1 second. All right, so biologics are a very new and interesting treatment modality for chronic low back pain. What biologic interventions mean essentially is using cells to treat our pain. So instead of taking medications or using steroid injections or using electricity to treat our pain, we actually use the body's own healing cells. The types of biologic injections that I perform are PRP, or platelet-rich plasma, and bone marrow aspirate concentrate, or BMAC injection. Some would call that a stem cell injection. I did a previous lecture probably 6 months ago on regenerative medicine. I spent about an hour going through some of the basic science and research and helping folks understand how and why these interventions work. So if you're interested in more of a deep dive into the physiology of these interventions, check out our YouTube channel, and there's a lecture on that where I go in great detail. But essentially, at the simplest form, what we are doing is taking your body's cells, either from your blood with PRP or from your bone marrow with BMAC. We're processing those cells in a centrifuge to concentrate the cell types that are most involved in healing, namely the platelets and our mesenchymal stem cells, or MSCs, from our bone marrow. And then we're using special techniques to inject those cells directly into the site of pathology. And so typically that is our intervertebral disc and our facet joints of our lumbar spine. When we look just briefly at how these interventions work, platelets are full of growth factors. This is just a handful of the growth factors that are contained within platelets. There's over 1,200 growth factors and proteins within each platelet. And platelets are intimately involved in wound healing. We can see here that most of these growth factors are involved in things like collagen synthesis, which is the building block of our discs and cartilage, blood vessel formation, which is important for wound healing, and then the ability to essentially have other cell types be attracted to the platelet environment based on these growth factors that are also involved in wound healing, such as our MSCs or stem cells that are already present in our discs, but relatively senescent or quiet as we age. So this represents a pretty ideal candidate for an intradiscal biologic procedure, be it PRP or a stem cell injection. We can see here, this is our lumbar spine. So this is our lowest lumbar segment, L5S1. You can see this disc, again, looks different than the others. It is drier than it should be. So we've lost that shock absorbing property to our nucleus. And then we also have a small tear in our annulus. And this disc is relatively isolated in that this patient looks relatively young. They have a single disc that's involved. This is a clear pain generator in this patient and would be amenable to treatment. When we have more severe disc degeneration and disc height loss or collapse, or it's really multi-level disease, this type of treatment becomes less effective because there is more pathology occurring. But this type of MRI, this type of patient tends to be ideal. And you can see here what a schematic of a disc injection looks like, where we use a special catheter that gets inserted either above or below the nerve root. and directed to the geometric center of the disc. And then we pressurize this nucleus with our concentrated cells that we've obtained from your blood or bone marrow and processed by centrifugation. And those cells flow through these tears and degenerative areas through the path of least resistance, now that there's pressure in the center of the disc. And they will fill these tears and help to heal tears and improve collagen structure and ultimately, and most importantly, improve pain in patients. This type of treatment is not universally helpful for every patient with every type of pathology and every time point, but is generally helpful for the majority of patients that have chronic disc disease that's relatively isolated in nature. So it represents a new, exciting area of treatment that we at VSO are providing to our patients. So finally, surgery. So say we have chronic back pain, chronic back and leg pain. We've given it some time. We've treated it ourselves. We've worked on physical therapy. We've tried several medication classes. Perhaps we've tried steroid injections for our nerve roots and our joints. We've tried an ablation, and we simply have persistent pain. That's where surgery comes in for most patients. It's also indicated for acute neurologic deficits. So we have a herniated disc, we have severe pain in our leg with associated weakness and difficulty walking. That is also a more urgent indication for surgical intervention. My general advice for patients is to seek out a surgeon who performs the most minimally invasive surgery to get the most maximally positive benefit out of the intervention. And our neurosurgeon at VSO, Dr. Braxton, really specializes in minimally invasive spine surgery, often done through cannulas with instruments using a microscope, although at times patients do require a more thorough surgery, such as a decompression infusion. But try and get away with the least invasive surgery that you possibly can. And seeing a surgeon like Dr. Braxton, who really focuses on that type of surgery, can be quite beneficial for your long-term function and recovery as well. So that brings me to the end of what I have here in terms of information. I'm happy to answer any questions. I hope I've kind of gone over pertinent anatomy, common causes of back pain, typical and newer regenerative treatments that are available for these type of pathologies. And I'm happy to spend some time and answer any questions that folks have about back pain or the spine or anything in general. So I guess I'll turn it back over to Rachel. I think, Rachel, you're going to help me proctor this and read through. And
Definitely.
Thanks for your time, and let's do some questions.
Thanks, Dr. Gnirke. It looks like we have a few already. Before we get started and let a few more questions trickle in, I just want to let everybody know that we are going to be doing a live in-person event with Dr. Braxton on November 3rd. Just because I know Dr. Gnirke mentioned that. So wanted to keep you guys on the lookout for that. All right, let's jump right in here. So Stephen asks, I've had 2 disc laminectomies to relieve L5-S1 herniations in 2015 and 2019. Since then, I've had intermittent episodes of back discomfort. What are signs or conditions that would indicate disc fusion surgery is recommended? In other words, the disc has failed completely and must be fused? Question mark at the end.
Yeah, sure. So a very common issue. So, surgery often doesn't make our spine normal, right? It addresses acute issues that we have and relieves pressure on our nerves is the most common indication for surgery. And so typically when folks have had a chronic history of degenerative disc disease, often they have Faceturing Arthritis as well. And so this is a scenario that I would highly recommend Steve, come into clinic, go through that history, run through a physical, update some imaging, and then see what we're dealing with in the current moment with regard to any disc degeneration or associated Faceturing arthritis. There may be some more minimally invasive interventions that could be helpful, particularly for our joints. And it really depends on what we look like on a physical exam and what our imaging looks like at this point. But I'd be happy to help with that. If that's something that you would like to be further evaluated for, feel free to come in and we'll figure it out.
Cool. And then next question, looks like we have, if I have pain on my buttock area that provokes a burning sensation, would that be something that could be part of your back pain treatments?
Absolutely, yeah. So pain in the buttock. So the buttock is an area that can manifest pain from several areas. It can be from our lumbar spine, from our lower lumbar segments, can be from our SI joint, from our piriformis, muscles, occasionally from our hip joints or hamstrings. And so that certainly has the ability to be many different types of pain based on what you described. And so again, I would just say that the best way to figure that out would be to come in the office, and we can help figure it out with a nice detailed physical examination and likely some imaging to see if there's any degeneration or pathology in our lumbar spine or in our sacrum or SI joints.
Hey, Peter asks, how do you choose between PRP and stem cell treatment?
Sure. So they're both more similar than they are different. So essentially a BMAC or stem cell injection is a PRP injection. So we're either drawing our blood from our vein or our blood from the area of our body where it's produced, which is our bone marrow. There's some data indicating that bone marrow injections or stem cell injections are slightly, but not dramatically more effective than a PRP injection. Often it comes down to patient preference in terms of the procedure itself, in terms of what the patient is looking for invasiveness. Obviously, drawing our bone marrow is more involved and invasive than is drawing our blood. So that can be one deciding factor. But overall, I consider them much more similar than they are different. And so that is something that we decide on a case-by-case basis, just on conversation with the patient.
Okay, Ted asks, sorry, 1 second here. Ted asks, what is the best and most effective procedure for minor to moderate stenosis for hip pain?
Oh, sure. So let me see. I didn't hear the last part. Mild to moderate stenosis for hip pain. Okay. So assuming that the hip pain is due to the stenosis. So certainly we can have more than one thing going on. So we can have spinal stenosis in our back, and we can also have hip pain as a result of arthritis or labral tears or tendinitis of our psoas tendon, et cetera. But typically for minor to moderate stenosis, we start conservatively, assuming all of our symptoms are from our lumbar spine. So we start with good physical therapy, making sure our biomechanics look good, work on our posture, our core strength, our flexibility. We may try some nerve pain medicines with minimal side effects. And then beyond there, if we have persistent symptoms, often an epidural steroid injection can be helpful, where we deliver steroid directly to the site of stenosis. So coat those nerves that are creating your hip pain with steroid. And so that can be often a long-term treatment, more in the mild to moderate category of stenosis. Once we get to more moderate to severe stenosis, it becomes more of a short-term treatment on the order of months. But some patients with mild to moderate stenosis do experience really long-term improvement with a single steroid injection.
Next question from Dave. You mentioned the use of heat and ice for treatment. How do you determine which one is appropriate?
So I typically say whichever one feels better. Typically for acute issues, so you're out in the yard, you threw your back out. So these very hyperacute issues that just occurred, ice is often most appropriate. But beyond the first kind of 24 to 48 hours, I personally typically recommend heat and a light stretching routine, because it's a careful balancing act between rest, inactivity, and overactivity. And so we want to have some degree of activity and stretching and moving our muscles and tendons and ligaments in our spine. So typically beyond the very acute period, heat is preferred, but at the end of the day, it is whatever feels better for the patient.
Janet asked you 2 questions. I think, is Biologics the same as the disc seal procedure from Dr. Kevin Prauza in Texas? And I think she wants to know if Biologics are generally covered by insurance, which I think that might be a more specific question for your provider, but.
Yeah, sure. So I don't know Dr. Kevin Prauza in Texas, but the disc seal procedure is typically a fibrinogen procedure. So it's a platelet derived procedure. So very similar to PRP. I can certainly go into kind of the pros and cons of those, but they're very similar overall. I would say a disc seal procedure using fibrinogen from your blood is very similar, but not the same as a PRP injection. Just the concentration of our cells and what we're actually injecting is slightly different, but very more similar than it is different. And then in terms of insurance coverage, so it's not universally covered by insurance. Medicare and Medicaid are big public insurances, do not cover these procedures yet. I think they're still considered experimental. The experiments that have been done in terms of clinical studies have been very positive for the majority of patients, not 100%, but the majority of patients do see benefit with this intervention, assuming a correct diagnosis. Work comp insurance in Colorado, unlike Medicare and Medicaid, it is a little bit more on the cutting edge, believe it or not. So they're very evidence-based. Given that the evidence is positive for intradiscal biologics as well as biologics for knee arthritis and rotator cuff tears and tennis elbow and several other diagnoses, these actually are covered fairly routinely by workers' comp insurance in Colorado, depending on the diagnosis and payer source. So I see that really as the first wave of insurance coverage. Kaiser Permanente, which is a closed system that's not around up in the mountains, but they also cover PRP for certain diagnoses because they see it as truly effective and as a way to save cost and save folks from needing to have surgery. So I think it's coming. It's still in the experimental stage. So kind of look out over the next 5 plus years, and I do expect that to change at some point, especially with our more well-studied diagnoses such as knee arthritis and tennis elbow and rotator cuff pathology, where these interventions have been used for over a decade with really good results.
I'm going to jump back into the Q&A box because we have a few questions popping up in here. So Karen asks, for an elderly patient with multiple areas of disc compression and stenosis, do you think RFA could work? She said steroid injection did not.
Yeah, so that really depends on the symptoms. So that's the importance of taking a good history and performing the physical examination. Specifically to your question, I would say that RFA is not used for spinal stenosis or disc compression, but is used for an associated type of pathology, Faceturing arthritis. And so typically when we have disc compression, that compression of the disc will put extra force through our facet joints, and you do develop back pain as a result of Faceturing arthritis. That's often associated with degenerative disc disease. So certainly for the facet, the arthritic portion of that pain, RFA can certainly be helpful. So it really depends on our symptoms. If it's more back pain than leg symptoms, certainly RFA may be helpful. If it's more leg symptoms as a result of spinal stenosis where we're having nerve pain, I would not anticipate an RFA to be effective in that scenario. So happy to, again, parse that out further in clinic if you'd like to come in and have a discussion about it.
All right, next question. With L5-S1 fusion due to I'm sorry, can you pronounce that word?
Yeah. Retrolithesis, yeah.
What have you seen regarding probabilities of feeling better, the same, or worse after recovery? Are there other treatments other than fusion for this issue?
Yeah, again, so I think surgery. This is definitely a surgical indication when we have alignment abnormalities in our spine, especially if it's associated with significant spinal stenosis, where our nerve health is affected by this alignment abnormality. So it would depend on our symptoms. Certainly, if we have leg symptoms as a result of nerve root compression due to the spondylolisthesis at L5-S1, I would anticipate those to fairly significantly and quickly improve with correcting the alignment and fusing that level. If there are other sources of back pain, so say it's muscular or say it's facet joint related pain, that too can certainly improve with fusion surgery. There are some other interventions short of surgery that also may be helpful. So it depends specifically on symptoms and associated, and if there's any associated neurologic deficits. But I think that, just on the face of it, does seem like a very reasonable treatment for that, although would want to know the degree of retrolithesis and degree of associated spinal stenosis, disc degeneration, and Faceturing arthritis. But certainly can be quite helpful for that.
Next question from Young. I occasionally have muscle pain in my lower back. Massage seems to help. Are there other treatments like NSAIDs that may help, and what can be done to prevent it? Yeah,
absolutely. So yeah, muscle pain, again, exceptionally common, the most common cause of this acute intermittent back pain. Often it's the result of injury. So just working on our biomechanics, making sure we're not doing any poor biomechanics with lifting or with hiking or skiing or biking. There may be some modifiable portion of our spinal mechanics that could help prevent that from coming back. Maintaining a really good, strong core is important so that we can use these muscles to support our spine. Stronger cores are associated with less muscle pain. Once we get through the initial kind of conditioning period where, working out is often, causes soreness and pain. But once we get through that initial period, often that helps change the trajectory over the long term. Over-the-counter NSAIDs, if there's no contraindication in terms of your other medical conditions or medications, can absolutely be helpful. If there's certain physical activities that typically flare you up, I often recommend folks take 2 Aleve tablets, depending on their renal function, before physical activity to minimize a flare-up of muscle pain afterwards. So I think biomechanics are a definite intervenable option there, and then anti-inflammatories over the counter can be quite helpful. And I myself have muscle pain in my back when I do a lot of activities, so we'll take a couple of Aleve typically before activities like that.
Next question from Carl. Are there any risks to biologics? Are there cases where a patient experiences more pain after this procedure?
Sure. Oh, that's an amazing point. Thanks, Carl, for bringing that up. I should have brought that up myself. There absolutely are risks. There absolutely are risks to every procedure. There are risks to doing procedures. There are risks to not doing procedures. So everything in life has its risks and benefits. With any injection in the spine, the risks are similar, although their distribution is somewhat different. So there's always a risk of infection, which is a big deal in the spine and requires IV antibiotics and potentially surgical intervention. There's a risk of bleeding with any intervention. And then there's always a risk of side effects of medication. So when we do these procedures, we don't only inject the biologic cells. We often typically inject anesthetic medicines. We may use antibiotics as well, either within the disc or IV or both is typically what I do with intradiscal injections to minimize the risk of infection. So there are potential risks of the medications used. Typically, though, these interventions are very well tolerated and do help the majority of patients over the long term. In terms of feeling more pain after the procedure, that's actually a very good point. So with biologic interventions, you can kind of think of them as the opposite of a steroid injection. So steroid injections make us feel better typically right away or within a week and last for several months and then begin to wane in their effectiveness. Biologics are the opposite. So in almost every patient, they experience an increase in pain for a period of 1 to 2 weeks. And then typically the effectiveness of the biologic injection takes several weeks to several months to manifest. And it can take longer in the spine than say in the elbow or the shoulder. Can take up to 6 months to notice significant positive benefit with a biologic injection. I would say it's very rare to have worsening of pain over the long term, so several months post-procedurally as a result of the procedure. It's very rare. It's much more common with other interventions. But biologics, luckily, are using your body's own cells, so there's limited flare-up over the long term, assuming no procedural complications or side effects that we talked about earlier.
Okay. I'm going to jump back into the chat box just because we have a few more questions coming in there that I haven't answered yet. Sorry, let me just find this one. So Peter wants to know what forms of back and muscle exercises are best for the back.
Oh, for sure. So it depends on your level of activity, right? So some of us are much more physically active than others. I would say as a general recommendation, I really like isometric core exercises. So things like planks, side planks, Superman pose, where we're maintaining a stable alignment, but activating our muscles. What I don't really like are repetitive flexion extension type exercises to build our core. So that would be, doing 1,000 sit-ups a day, doing the Roman chair extensions, where we're getting a lot of motion through our facet joints and discs. I think that more isometric based core exercises tend to be the most effective in terms of improving our core function while limiting any irritation of our spine while doing these activities. So those are what I prefer the most, and they're just as important as stretching. So stretching of our pelvis is just as important as strengthening our core so that we can send motion that we would otherwise through our lumbar segments, through our hips and knees.
Okay. Is radio frequency ablation effective with stenosis?
It can be with stenosis, yep. So I would say it's not targeted for stenosis, but often patients who see benefit with radio frequency ablation, the reason why they see benefit is because they have symptomatic arthritis. As our joints develop arthritis, they enlarge and they tend to produce spinal stenosis. So while you can have spinal stenosis and arthritis, and they can be interrelated, the radio frequency ablation is specifically targeted at the arthritic portion of our symptoms and doesn't necessarily treat spinal stenosis directly, but certainly patients with spinal stenosis can experience significant improvement in their arthritis-related pain with radio frequency ablation.
We have a few questions coming in just regarding biologics and PRP being covered with insurance. I think we kind of generally answered that. I don't know if you want to touch on it more, if you think you were okay to go to the next question, Dr. Gnirke.
Yeah, I think, right now they're typically not covered by private or public insurance outside of workers' compensation insurance, which does cover it fairly regularly for certain diagnoses. Yep.
Okay. And Amy asked, can you talk about stress, insufficiency, fracture symptoms and treatments now or in a subsequent lecture, she asked.
Sure. So I can give a little blurb now. I can certainly make that a topic in the future. So, stress or insufficiency fractures are a distinct type of fracture, often associated with osteoporosis or poor bone mineral density, particularly the insufficiency fracture portion. Stress fractures are closely related, but often a different type of pathology. Actually, one of the more common causes of back pain in kids are stress reactions and stress fractures of their L5, pars interarticularis, which is a portion of the bone in between the facet joints. So certainly stress and insufficiency fractures are very common, and I think that would warrant a whole other lecture talking mostly about bone health, and certainly can put it on the list for future topics. Thank you.
Does anyone still inject cortisone into the problem areas any longer?
Absolutely, myself and many others. So steroid injections, we use a newer version of cortisone called Kenalog, or one of its closely related medications called dexamethasone. And that can be used as a targeted treatment for spinal stenosis and arthritis. Cortisone is kind of like the grandfather of all of the modern corticosteroids. And so there are some kind of better, more effective, longer lasting steroids out there at this point that we use. But yeah, absolutely.
Steve would like to know, what exercises do you recommend as we age to keep our backs strong? I know you touched on that briefly, but if you wanted to explain.
Yes, I think that parlays into the question a few questions ago. Really, I like isometric core exercises. So planks, side planks, Superman pose, laying on our back, doing scissor kicks, where we're keeping our spinal alignment neutral by activating our core.
Okay. Jeanette wants to know, do biologics heal and restore degenerative discs or just help with the pain temporarily?
It can be both. So it can be both. So there are the underlying thought in terms of how biologics work is they kind of make an old injury that hasn't healed into a new injury with the cellular machinery that it needs to heal, namely the platelets and stem cells. And so platelets particularly are full of growth factors. So essentially what we're doing is delivering growth factors directly to the site of pathology. And so those growth factors, the aim of those growth factors is to heal your tissue. So to heal your collagen tears, be they annular tears or disc degeneration, and to provide blood vessel support for that wound healing. There are studies, and just talking to patients, looking at imaging studies. There are both research studies and just clinical evidence showing improvement in imaging as well. That's not universally true. So not every patient sees significant improvement, say, in their MRI evidence of degenerative disc disease. But certainly you can see frank imaging improvement as well in terms of the degree of degeneration or tearing to the disc. And then, the goal is to improve pain, but they improve pain through those wound healing properties of the cells. There are certainly some pain relieving properties in some of those growth factors and proteins, but really the goal is long-term symptom improvement, which may or may not manifest as improvement on imaging as well.
Okay. Lloyd would like to know, or he says, I have herniated discs in the lumbar and cervic areas, plus x-rays showing a lot of arthritis and pinched nerve in the neck. I have learned to cope with it, but now becoming more painful, especially with regards to walking, standing, and hiking uphill. Skiing and biking are no problem. What now?
Yeah, so it certainly sounds like we have symptomatic stenosis. So we've transitioned from a relatively asymptomatic or manageable type of stenosis to a more chronically bothersome type of stenosis. Likely the degree of stenosis or the severity has progressed over time. And so, if these symptoms are limiting our physical function and causing progressive pain, often that's a good clue that we should come in, meet a physician, get your imaging updated, understand what we're dealing with from an anatomy standpoint, and then come up with a more detailed treatment plan, be it optimizing our conservative care with our physical therapy and home exercise program, or more likely in that case, a more interventional plan with procedures or potentially surgery, depending on what our symptoms, physical exam and imaging looks like.
Okay. Judy asks, or sorry, her comment is, my husband has gone through PT, core strengthening, and epidural injections for spinal stenosis. He's had trouble since 2017 and it's worsening. He's in pain every day. What would his next steps be?
Yeah, so essentially what that's describing is a failure of conservative and interventional care. So we've given it time, we've worked on physical therapy, we've worked on our biomechanics with core strengthening and pelvic flexibility, we've tried injections, likely he's tried some medications along the way. So this becomes an indication for surgery, depending on what our imaging, what our anatomy looks like. So that is something that may ultimately require a decompressive type surgery to relieve pressure on the nerves, as we have, certainly tried other treatments in that case, and unfortunately they have failed, which, is the case. Luckily, less than 10% of patients that have spinal stenosis ultimately require surgery, but, certainly patients do require, certain subset of patients do require decompressive type surgeries to manage their symptoms that are refractory to other types of treatment.
Jeff wants to know about the efficacy of radiofrequency ablation when it comes to spinal stenosis.
Can you say the last part again? When it comes to
spinal stenosis.
Oh, spinal stenosis, yeah. So I think we touched on this a little bit earlier, so maybe this question answered already, but I'd say spinal stenosis is a related but different issue than what a radiofrequency ablation is targeted at. So spinal stenosis is often due to pinching of your nerves from Faceturing arthritis as the joints get enlarged and disc degeneration. An ablation does not treat spinal stenosis. So an ablation treats arthritis-related pain in the spine, and that arthritis certainly can contribute to spinal stenosis, but the treatment of radiofrequency ablation is really targeted at the pain related to the arthritis and not the spinal stenosis. And there are other treatments for spinal stenosis related pain, such as epidural steroid injections or surgical intervention.
We have one more question. An anonymous attendee asks, what diet is best for bone health?
Oh, sure. So a healthy diet, so free of processed foods, with whole foods. You want to make sure that you're getting plenty of vitamin D as well. So outside of our diet, especially up here in the mountains, making sure we're getting some sunshine in our life or supplementing if we cannot. A diet with some dairy in it will provide the vitamins we need as well as calcium. But generally eating a healthy whole food based diet is what's going to be most helpful for our bone health. And beyond diet and vitamin D with sunshine, what's just as, if not more important, is resistance exercise. So putting some resistance through our bones. So our body, has this kind of paradigm, you use it or you lose it. And so if we load our bones with even light resistance exercises like dumbbell curls, weighted body squats, things along those lines, we're actually weighting our bones. That has been shown to be significantly helpful for maintaining and improving bone mineral density.
All right. Well, Dr. Gnirke, I think those are all the questions. If anybody else has more questions, please feel free to reach out to us. And please don't hesitate to reach out and get an appointment scheduled with Dr. Gnirke and his team. Thanks for attending.
Yep, thank you very much, Rachel. And thanks everyone for your attention. I really appreciate it. And I'll catch up with you in a few months for the next lecture. I'll see
Absolutely.
See you later. Thank you.
All right. Have a great one, everyone.